a steering committee that's comprised of the organizations on the screen before you. Chooses the topics based on what's timely and also nuanced and complex, and we think we've got a good one for you today. Those organizations are the National Forum for Heart Disease and Stroke Prevention, the National Patient Advocate Foundation, the National Osteoporosis Foundation, the Alliance of Community Health Plans, the Caregiver Action Network, and the Association of Black Cardiologists. We hold these meetings quarterly and are certainly welcome to ideas from anyone about future topics. Today, the focus is on innovation and collaboration in utilization management. I guess it's easier to start with what we're not planning to cover today, which is sort of the more traditional look at the current landscape of utilization management. I think many of us know the pros and cons of that environment, and that has been talked about and discussed for many years. And many of us have been active in various advocacy fields trying to bring reforms to those processes. What we're focused on today is really thinking about opportunities to innovate and rethink utilization management in certain places, in certain therapeutic areas where it may be appropriate to do so, particularly where there's opportunities to collaborate in the design and execution of utilization management strategies and really incorporate them more on the front end of care rather than on the back end of care decisions, and also to think about utilization management in the context of personalized care, not just personalized medicine, but personalized care. So to the extent that there are opportunities in certain therapeutic areas to really think about not just inappropriate variation in care, which is certainly an appropriate concern that utilization management can guard against, but also thinking about appropriate variation in care, which right now a lot of not just utilization management, but the clinical care delivery paradigm is not necessarily engineered to inherently to think about appropriate variation in care in a systematic way. And all of this in light of a shift in the reimbursement paradigm from fee-for-service to more value-based payment models. And we'll certainly get to that as we move through this discussion. We have three great panelists for you this afternoon. I'm going to be kind of playing the role of both moderator and panelist to represent the patient voice. I'm the CEO of Patient Advocate Foundation as well as National Patient Advocate Foundation. We have Jay and Robin and Kate here. They will introduce themselves when at the start of their first introductory remarks to the first discussion topic. We've divided the conversation into three parts today, hoping to kind of weed through them equally. The first one will be just a quick reminder of sort of what are sort of the key elements of utilization management and what is there interest in collaborating and rethinking that paradigm in certain areas and what might that look like? We will then switch to a few specific examples and sort of maybe incremental or marginal opportunities to improve utilization management. And then finally, and probably where we'll spend the bulk of our time is thinking about how the intersection of redesign or rethinking of utilization management practices and value-based payment models and sort of risk-based or two-sided risk models may actually be a perfect marriage in some places for both rethinking or taking a different approach to utilization management or achieving the goals of utilization management, but also achieving the goals of getting away from fee-for-service to volume-based payment models. So with that, I'm going to go ahead and jump in. Please enter any questions that you have in the Q&A. We did allow for about 10 minutes of that at the end. I will monitor that as best I can, and if there's something really timely or a clarification as we go through these discussions, I'll try to chime in or weave them into the discussion. But for the most part, we'll get to those at the end of the Q&A, but feel free to enter them as you go. So with that, I'm going to kick off. I'm going to ask Kate to start off, and then Jay and Robin in order. And if you could just give some preliminary thoughts on these two questions. One is sort of what are the key design elements that need to be considered for any alternative to or innovation in utilization management? And then is there interest on the part of payers and health systems and clinicians to explore alternative forms of utilization management that emphasize a more multi-stakeholder and collaborative design?
Well, Alan, thanks so much for having me as part of this panel. I'm really pleased to participate. I'm Kate Berry, Senior Vice President with America's Health Insurance Plans, and I work in the clinical innovation area. So I have the great pleasure of working with chief medical officers and other clinical leaders across our health plan membership. And just to share a little bit about AHIP, we represent health plans that cut across kind of the entire spectrum of, Medicaid managed care, Medicare Advantage, commercial insurance, the Affordable Care Act, and employer-sponsored insurance. So the full gamut, and including, small regional plans, national plans, and fully integrated systems as well. So, just to start with a few highlights, we actually completed a health plan landscape survey on prior authorization and utilization management just about almost exactly a year ago, which seems like an eternity prior to COVID. And by the way, we'd be remiss not to acknowledge that today is a very big day with vaccines starting to be administered in the US. So, and I'm happy to be talking about something other than vaccines today because I spent a long time on the weekend monitoring all of the latest there. But so our landscape survey, just a couple of super quick highlights because I think everyone does understand sort of the purpose of utilization management, but there are a couple things that health plans do that sometimes folks don't fully understand. So one, the utilization management programs are designed based on evidence. So health insurance providers use peer-reviewed studies, they use federal studies and guidelines, and they use provider specialty organization developed clinical guidelines as part of designing their utilization management programs. They also incorporate provider input into the process in multiple ways. So provider input is a part of the process. And utilization management programs are really targeted and selective in focusing in on areas to protect patient safety, to address, wide variation in practice. Some of the areas where utilization management is particularly focused is on things like high-cost specialty drugs, on high-cost imaging, on genetic testing, for example. And just one other example I'll use, from the survey that oftentimes folks don't necessarily realize is that health plans, they review all of their utilization management programs at least annually and oftentimes twice a year to both incorporate new evidence and to look at data and adjust based on performance. And then finally, the only other thing I'm going to say about our survey results that might be of interest, and it gets to the question, Alan, around a willingness to collaborate and a desire to improve the process, recognizing that it can be burdensome. And so, the three biggest opportunities for improving utilization management programs that was, identified in our survey include automation or going electronic, and I will share, some work that we're doing in that regard. Another key opportunity for improvement that was really identified. So 84% said, automation or going electronic can really be helpful. About 50% said, the provider plan collaboration around risk-based, performance-based contracts is also a very important opportunity to improve. And then finally, following evidence-based guidelines, so getting to your clinical path. So I think those are three really important opportunities to both collaborate and improve the process. Thank you.
Thanks, Kate. Jay, you want to jump in and give your own thoughts about opportunities to collaborate and maybe respond to some of what Kate had noted about, the need for utilization management in whatever form needs to be evidence-based, have provider input, I would also talk a little bit about the potential for patient input, targeted in certain areas, and really thinking about cost as a factor.
Sure. Yeah, thanks for having me. My name is Jay Scott, and I am the Director of Managed Care for Minnesota Oncology. We're a Twin Cities-based large independent oncology group with a national affiliation with US Oncology Network, which is a network of community-based oncologists around the country. So just to do my best to answer some of your questions, I think that it is key to work on medical policy and utilization management as a collaboration and a partnership between payers, providers, patients, employer groups, I would add, and sometimes even the government. I think that in our state, we have worked with the provider or with the payer community quite a bit on a number of utilization management policies, and we have a lot of alignment. I think that the desire to improve quality, try to eliminate as much as possible the low value care, what is often perceived as waste in the system, is essential, as well as improve the patient experience, which I think is essential. So we've worked here to try to decrease our administrative burden at the same time so as not to add cost to the provider's bottom line as well, so that we can focus as much as we can on reinvesting in patient care. And so I believe that adherence to national guidelines is really essential. We have built into our electronic medical record evidence-based adherence to the national NCCN, National Comprehensive Cancer Network guidelines. And further, we've kind of taken the next step where we have the opportunity to look at value within those guidelines, and we try to include value-based care for our oncology patients as well. So we're really trying to work with the payers and the community on providing the highest quality care at the lowest cost or the right cost, and with the same patient experience.
Thanks, Jay. So Robin, so what Jay added to what the sort of Kate's outline of some must-haves was really eliminating, and I think there's a lot of overlap already, eliminating low-value care, increasing quality, improving the patient experience, reducing the administrative burden, and really thinking about multi-stakeholder collaboration as a key.
Great. So my name is Robin Zahn, and I am a community medical oncologist, and have been in practice for 22 plus years in the Michiana area. Michiana is in the South Bend, Southern Michigan area, South Bend, Indiana. That being said, I've held a number of leadership roles. I was the PI of a very successful CCOP for over a decade before the change in the research network. I also served on the board of directors for ASCO, as well as chair of the Government Relations Committee, the Clinical Practice Committee, as well as the chair of the Clinical Pathways Task Force. And that work has now blended over into the steering committee and work with the Journal of Clinical Pathways and the Oncology Congress. So I've had a lot of work in advocating for both patients as well as providers in the delivery of cost-effective but high-quality healthcare. The prior two speakers, both Kate and Jay, really touched upon many of the same points I was going to touch upon, but I wanted to add just a little bit of a provider perspective as well. ASCO had actually published a utilization management principle document a couple years ago because of the concerns they were hearing from providers of the challenges that we were being faced in being able to deliver high quality care for our patients. And utilization management policies were actually quite overwhelming, and they continued to grow to be overwhelming without, in many of our opinions, actually adding to the benefit of the patient. Within that particular policy statement, there was concerns that the patients be provided full access to all the care that they needed, that they received most appropriate care, of course, based on the highest level evidence that's available, that cost be considered but not be the primary driver of care, and that there be transparency as to who is making the decision and what conflict of interest may they have while they're making those decisions, and that there be minimal administrative burden. So that adds on a little bit to what was been said, but I also would suggest that in addition to the design elements and going forward, I could not overemphasize what Jay and Kate had both said, and that's being very broad into stakeholder representation. That includes not just the patients and the providers, but also the health plan representatives and the employers, because they're obviously providing 50% or more, of the benefits for the patients that we're seeing daily. But I also would put a spin onto that stakeholder collaboration and suggest that there be assigned accountability to the appropriate stakeholders. For example, physicians and providers, should be accountable for the utilization and for prescribing, of certain techniques and diagnostics and imaging, as well as the drug therapy. But we shouldn't be held accountable for the drug cost, especially when there may be other relationships that are going to be in that room that are not necessarily transparent, that may be actually driving what the choices may be for certain health plans to pick particular drugs, for example. I also would suggest that we need to be thinking forward as to evidence. And what does evidence really mean? Evidence right now is based on what's NCCN and what's ASCO, that's based on clinical trials that represent 3 to 4% of the population. We see the rest of that population that walk through our door, and none of them ever look like the patients on those clinical trials. That being said, real world evidence is on its way. And something that we should be thinking about as a collaborative group is how do we integrate that real world evidence with rules, of course, and boundaries. I'm not saying we have the solution, but there needs to be consideration of how to integrate that real world evidence. So in fact, we are giving personalized care, not just personalized medicine, but actually care of the individual and including the patient preferences.
Thanks, Robin. That's an excellent point. So we're going to move into sort of section 2, but before that, I just wanted to maybe give a few quick comments from a patient perspective. I think we all understand there are limitations around the current form of utilization management, and we'll talk in the next section about what I would consider more incremental opportunities to improve on the current state, not necessarily innovative, but things that can be done to make the process more efficient or less burdensome that will help patients as well. And then the last section will kind of get into that more, sort of how do we really change the paradigm and in what circumstances. But before we get to that more incremental or examples of things that have been done to improve on different ways of utilization management, I think from a patient perspective, what's often, I do think payer, plan, clinician collaboration is really important. But at some point, if the goal is really to if the inherent design is to try to create a process that leads to the maximum likelihood that the right patient is going to get the right care at the right time, there has to be a way, and if that process is somehow tied to approval or authorization or coverage, then involving the patient in those discussions, I think it's going to, not in every case, but in certain therapeutic areas, in certain cases, I think it's going to become very important to how we think about new forms or different approaches to utilization management. And so we'll touch, I think, more on that as the discussion unfolds. But I think patients also have a lot of the same priorities in terms of making sure that they're not exposed to unnecessary cost burdens, that they're not exposed to unnecessary wait times or exposed to therapies that may not be the right thing for them. Certainly understand the need for real world evidence or for some of their personal experiences and goals to be incorporated into the conversations and the decision-making process. So we'll, I think, touch on those as we move through the discussion, but I wanted to put down a marker for those up front. Is I do think in some of these care delivery processes and how they might align with payment models, there is an opportunity to really involve the patient, both in collecting real world evidence, but also in bringing them into the conversations about stewardship around cost, around understanding appropriate guideline concordant care, et cetera. So before we get to that, though, why don't we start with maybe a little bit easier lift, which is thinking about, what are some examples that you might cite or some opportunities? Kate, I know you already touched on one, sort of the efficiency that could be brought to the process that certainly would benefit everyone in terms of administrative burden and reducing time to care. But maybe think about some examples of incremental improvements or things that you know of that have already been done that are collaborative in nature. That maybe a different approach to utilization management than the more traditional form, where at the back end the decision's been made and then you wait for it to be approved for coverage, whether it's a procedure or a medication. Are there other forms of utilization management currently that where there could be some incremental improvements, or there could be a different approach applied that would be more collaborative and that wouldn't involve decisions being made or the UN being applied at the back end of a decision? I'm not saying that's inherently wrong. I'm just saying as a different approach. Kate, we'll go Kate and then Robin and then Jay.
Thanks, Alan. So I wanted to share a little bit. I think it might be helpful for folks to hear about kind of, and you can call it an incremental approach, but actually implementing technology, that connects kind of all the key players and is focused on, ensuring that patients have timely access to care. It actually is bigger than incremental, I think, because it just in terms of the complexity around both the technology and the adoption of the technology and the full use of it. So we launched actually, it's quite some time ago now, a project to collaborate across multiple technology providers, multiple health plans, and the health plan provider partners, to kind of demonstrate that electronic prior authorization can actually make both the information about the utilization management requirements much more transparent to providers in the workflow, and then enable bi-directional electronic exchange of information between health, providers and health plans around this process. So, the goals that we set forth for the project really included, using industry established standards for electronic information exchange, that had the capability or the potential to be scalable solutions, that are payer neutral solutions. So, from the provider perspective, whatever coverage, whatever type of health insurance their patients may have, the solution can work for them. And then finally, that it's as integrated as possible with provider workflow. So those were our goals in kind of selecting the technology providers or the technology companies that we used. And we're using two different technology companies, one that's specifically in the prescription medication space, so that would provide electronic utilization management for medications. And then on the other side of the equation, we're also working with a technology company that has the ability to have electronic solutions around medical surgical procedures. So sort of looking at both of those pictures. And we have, as I mentioned, we have multiple health plans, and then the health plans are working with the providers that they collaborate with normally and have the technology available to them. So we've engaged RTI, which is a global research company, to perform an independent evaluation of the impact of this technology solution on both the provider workflow. So to Robin's point, we know this is burdensome for providers. It can delay care for patients. It's costly and burdensome for health plans too, quite honestly. But so looking at, RTI is going to be looking at the impact of the electronic process on the provider workflow. So do we reduce phone calls and faxes? Do we speed time to a decision? And then looking also at the patient experience and understanding, does the patient have better access to information about potentially the cost, the out-of-pocket cost of the medication that may be prescribed for them? Do they have, transparency around the process, and do they have a better experience in terms of timeliness to care? So that's sort of the focus of our project. And we are, it's been a long time in coming, because it takes a long time to coordinate all, to herd all those cats. and to do a rigorous study of the impact, but we are excited that we will have results of this project and evaluation coming early in 2021, so probably in the January timeframe.
Thanks, Kate. That's exciting. Robin, any examples you want to cite, or certainly welcome to react to some of what Kate was sharing as well?
Oh, sure. Well, I'm just going to share examples and just make the general comment that providers have been working for several years now, along with payers in a collaborative manner to try to make incremental change. Some examples include gold carding. You know, for example, there have been some associations that if they've had prior approval rates of 95% or greater, they automatically have gold carding, but then there has to be an audit to make sure that they're consistent, you know, in their choices. Pathways. There have been groups that have been using high quality clinical pathways with certain payers. And if they subscribe to a certain adherence rate, they're given automatic approval with, of course, audits on the back end, you know, to make sure on the payer side that in fact they are holding up, you know, the best high level evidence of care. Certainly there have been payers such as UHC that's worked with the cancer episode of care, which is a payment model. I know we'll be talking about that a little bit later, but part of that, in fact, is chemo prior authorization that can help, providers. Now, of course, that's when we get into shared risk, and I think we'll be talking about that later, but that is an incremental change and it actually is being discussed in the public. Certainly UHC, again, had worked previously with certain groups with utilization of pathways, also to help with prior approvals, but also to work together to reduce utilization management and administrative burden to make certain that the patients are getting their best care. We have OCM, okay, as we're all familiar with. We also have groups that are following what's called CINs, or clinical integrated networks, amongst the oncologists that are actually working with each other to go to payers to be able to help reduce the administrative burden and deliver best care. And finally, there's oncology medical homes. That is still in development. ASCO and COA are currently working on oncology medical home with one of the intentions is to just not only deliver care that can be timely and quick and perhaps reduce the administrative burden of utilization management, but also deliver high quality care with quality with regards to based on high level evidence of care, but also based on PROs, patient reported outcomes, and how patients are perceived that their care is being delivered.
Thanks, Robin. And just so everybody knows, I am not texting. I'm actually writing notes from the discussion. So that's why I'm looking down and scribbling. But Jay, any examples or comments from you?
Yeah, I think to piggyback on some of the things Dr. Zahn mentioned, we partnered with a number of community payers on gold carding, really with the same goals in mind, to adhere to the NCCN pathways and to our value pathways. And rather than audit, we actually let them come in and take a look at our medical record to begin with. But what we've done is we share a quarterly report with a number of payers in Minnesota, which shows all of the patients who would have gone through the prior authorization process should that have been in place. But instead, with the gold card process, we're pretty transparent about, you know, who stayed on the pathway and who didn't, as well as a component of value to that pathway. So we share with that. We share that data with them quarterly, and then we get together and they can ask questions about why something might have gone off pathway. And, you know, because that would have been a denial, obviously, in the past. And so I think that gold carding is an aligned incentive, I think, for the providers, patients, and the payers that can't be understated as long as you adhere to a certain percentage of their authorization. The second thing that I wanted to mention, too, that I think improves quality and decrease low-value care waste is using certain tools that are available now that may not have been in the past. Like for us, we use a tool called Navigating Cancer, which is a way for our patients to stay in contact with us through any type of device, and we talk back and forth. They're able to give input on symptoms or where they're at in their care, in their regimens of cancer treatment, and the providers are able to speak back with them. We see this as an opportunity to decrease a lot of the waste and unnecessary visits, and I think that it's especially relevant during COVID here. And then I think just the last thing would be, is, and I know we'll touch more on this, is when we look at value-based care, I think we all have to have some skin in the game and some risk or some type of monetary either incentive or penalty when it comes to providing the highest quality care at the right cost. And so we're looking at those type of either risk agreements or incentive agreements with the provider or the payers going forward. And I think that that's going to be a huge opportunity in the future.
Thanks, Jay. And a couple of quick thoughts to add to this. And just to, I'm going to describe gold carding in layman's terms to the best of my ability. Correct me if I get it wrong, but generally it's the idea that if a practice or a system comports with a pathway or a set of training or a set of guidelines, that the orders that come out of that practice will be automatically prior auth with either with an audit on the back end or some assurance built into the process that evidence-based care is going to be delivered, and usually with some attention paid to the cost effectiveness as a sort of maybe a third priority once you've gone through efficacy and safety. Is that a general acceptable description of gold carding as a concept?
That works, yes.
Okay. So yeah, I think those are, and another example that I don't know if we shared it with the audience beforehand, but the Seattle Cancer Care Alliance has an agreement if all of their radiologists are trained to a certain standard of guideline adherent care, that any orders that come out of that radiology team are automatically approved. So we raise these just to show that there's a lot of effort being paid to both thinking about how to reduce the administrative burden for practices and for plans around the current process, where there can be some, I don't want to say certainty, but some assurance put in place that some of those goals that we talked about up front are being made around evidence-based care, cost effectiveness, less, value-based care, et cetera. And so I think there are opportunities in that regard for what I would call incrementalism. And while those are important and they certainly do help patients, I think what's lacking is sort of how do you really bring the patient into the, there were some, and I know RTI is going to be looking at, does this benefit patients? Does it bring more transparency? Does it improve patient experience? But I guess as another way of thinking about fundamentally, if you use the idea of gold carding, how do you bring patients into the process of decision-making in a way that actually makes them part of the collaborative process? And I think we'll touch on that when we get to this next section on sort of the really not only thinking about the idea of reducing administrative burden, making the process more efficient, but thinking about alternative payment models and alternative care delivery models and how that may actually be much more fertile ground for really thinking about different approaches to utilization management. So why don't we segue to that topic, and why don't we start with you, Robin, on this one, and then we'll go to Jay and with Kate. And I see a question in the chat, so I'll document that for our Q&A. And maybe I'll tee this up with a little bit of a lead in. So part of what we advocate for, and I know others do as well, in sort of thinking about patient care delivery, is a paradigm of shared decision-making and care planning that really does build in key elements of the individual patient, and whether it's their genetic profile, whether it's their lived experience, whether it's their economic circumstances, the uniqueness of their disease, et cetera. Especially in a therapeutic environment where there are many options, where the efficacy and safety of those options are fairly equal, but really could differentiate based on key pieces of information about the patient. In those types of circumstances, we think, and what we advocate for, is that there could actually be a care delivery process that could be created almost like a pathway, but more of a care delivery pathway, where a set of processes around decision-making and care planning are put in place that are evidence-based, that sort of check all those boxes of what utilization management is designed to help create or guard against, guarding against low-value care, really emphasizing guideline concordant care, including cost into the conversation, other attributes of real-world evidence that may be relevant to the patient before you. So is there, so that when we think about sort of innovation of utilization management, if you have sort of a different care delivery model, and I think that would have to be tied, I think, to also a different payment model, would that create a new way to think about utilization management if those processes were in place around shared decision-making and care planning that had proper guardrails around them? Could that then also become a means, a sort of a gold carding, if you will, that if practices follow these steps and follow these approaches, and maybe in a risk-sharing environment, could that actually be a new approach to really marrying the goals of utilization management with the needs of personalization of medicine and care when it's appropriate to do so? Again, sort of thinking about how do you really get the right care to the right patient at the right time when you have an equal need to appropriately vary care while also reducing inappropriate variation in care. So with that, Robin, maybe you can comment on what's the future of alternative payment models, and thinking about how that may, maybe you disagree, that alternative payment models also have to come with sort of an alternative care delivery model if we're really thinking about new and innovative approaches around utilization management and getting the right care to the right patient at the right time. Sorry, that was a big lead into a question, but that I'm also playing my role of panelist in leading up to that question as well.
So the short answer is yes, but I'm going to expand on that. With MACRA, the focus has moved from and will continue to move from fee-for-service to alternate payment models. And why is that? That's because rather than rewarding folks for volume of care and revenues and profit margins, let's switch over to value of care. And value of care is, just as you said, delivering the best quality of care in a cost-effective manner. So the APMs, and of course the classic one is the OCM, that's currently under a demonstration project and under renewal. But along with that, there are folks who have been working on these APMs, and I talked previously about the oncology medical home. Certainly I would anticipate that part of that whole spectrum of that care model is looking not just at individual treatments or diagnostics. What you want is the total cost of care and the total cancer journey experience of the patient. So rather than focusing just on drugs all the time, it's important to focus on the entire care continuum to make sure that the outcome of that patient is absolutely optimized in a cost-effective manner. And that's where these APMs, the alternative payment models, can come in to allow for that. Included in that includes not just shared decision-making, but the PROs that we talked about, the triages, the navigating cancers, plus the other IT solutions that are surrounding not just the processes and the operations to make it more efficient, but also the evidence collection and how decisions are being made at the clinical point of decision-making, and then what the outcomes are for those patients. So it's a very broad view, more than what has been documented before, because everything has been fee for service. So it's a little bit here and a little bit there. This is a much more comprehensive approach. Do I think it can be successful? Yes, I do. Do I think it's going to be immediate? No, I don't. I think it's going to be an evolutionary process. And even the OCM was learning as it went through, and what works and what doesn't work. And certainly there are other payers that are working with providers and patients to try to evolve their APM. There needs to be shared loss and shared benefit. And I think one of the concerns you had is, what would we expect? Would we expect that there be reduction or improvement in utilization management? I think the answer is yes. But again, not to focus on just one particular aspect of the care journey. It needs to be a complete view of that care journey. So I would anticipate that moving forward, that the APMs will be focusing more as oncology care type models. And certainly OCM is one of them, with expansion and evolution, and moving away from the misaligned incentives, which were forced upon the providers, that wasn't chosen by them, but over to an area where they actually are rewarded for the valuable care that they want to give and patients want to receive.
Thanks, Robin. So Jay, what say you? Do you feel like alternative payment models is the right environment to really think about innovation around utilization management? And to what extent do alternative payment models have to be married with sort of alternative care models?
Well, I think that we have to move to a new model that's going to be different in both delivery and in reimbursement. I think that if we continue along the road of the misaligned incentives that Dr. Zahn mentioned, it's not sustainable. We know that as a country, the government won't be able to handle the trend of healthcare costs if we continue down that road. nor will the payers and the patients and the employers. So I think we have no choice but to move to alternative payment models. I think what those look like or how we implement, I think is up for debate and discussion, because I think we can be successful in a number of ways. For us, looking at some of the value-based care models, in addition to OCM, which has been extremely successful, by the way, if people are not sure about that, there's been hundreds of millions of dollars saved by in the OCM cancer model that people should familiarize themselves with. But beyond that, I think as we work with commercial payers, there's a huge opportunity to attribute patients to either care systems or independent providers. Basically, the provider who has the most influence on their outcome, the quality of care, their patient's experience, and the overall cost. And they should be the ones to really direct that care. So the delivery will change based on that attribution or enrollment into that type of program. I believe that, for us, we're looking at if someone is undergoing cancer care and they're seeing us for their chemo, and we have a good sense of, if they're going to the hospital, if they have an advanced care plan, if palliative care is in place, if there's the potential for end-of-life care in a hospice environment rather than in the hospital, that those are the types of things that are going to have a huge impact both on the patient's perception of their care in terms of experience, the family's perception, and of overall cost as well. And so I think that if we work together, with those partners, there is a huge opportunity to redesign care. One thing I did want to bring up, though, that sometimes should be considered in this conversation, and you brought it up earlier as it relates to the individual, the patient, or the healthcare consumer in this, is choice. Choice sometimes leads to additional costs that we need to talk about how to eliminate. So is somebody seeking 2 or 3 opinions when oftentimes those 3 opinions might be the same? Are they having imaging done that is duplicative in nature? Are there tests being done that one provider's already done that could be shared with another provider? Those are opportunities, I think, to involve the patient more in those decisions and help them to understand their benefit set and the care that I think is the desire of all involved. So choice is really a key component, I think, to redesigning the care model and the reimbursement model as we talk this through.
Thanks, Jay. And just as a quick reminder for everybody, MACRA is the Medicare Access and CHIP Reauthorization Act of 2015. And in that piece of legislation is a lot of the regulatory empowerment for quality payment programs like the ones we've been describing. Kate, so turning to you, do you feel like alternative payment models, and part of the reason why we surfaced this discussion here is because in the run-up to this webinar, when the 3 of us spoke about topics, everybody led sort of to this as, I don't want to say the holy grail, but sort of fertile ground for really rethinking utilization management. Really is sort of would go part and parcel with new payment paradigm models. And I sort of interjected, well, yeah, but payment models also mean new care delivery models if you really want to bring the patient experience more into the decision-making and care planning process to align the right patient with the right care at the right time and get to real-world evidence-based approaches. So Kate, talk a little bit about, from the plan perspective, do you see real opportunity here? Is this seen as an opportunity to collaborate and rethink not only payment models, but rethink care delivery models? And is sort of this risk-sharing environment the way to really get at either obviating or creating a new approach of achieving the goals of utilization management, but putting more of the discretion, if you will, at the hands of providers, and to Jay's point and my point, sort of getting patients involved in that decision-making as well?
Yes, I agree with a lot of what both Jay and Robin have said on this. I do think that, these alternative payment models, these sort of risk and reward sharing models that allow for alignment of incentives. And by that, to Jay's point, I would include alignment of incentives with the patient, to be a key decision, part of the decision process in terms of, optimizing outcomes. So yes, I definitely agree with this. It's, it has to some extent been a long journey. I mean, this has been a holy grail for a long time. And I think in some ways with COVID, it became even more apparent to everyone that fee for service can be, really, really challenging, when we think about innovative ways to engage patients, be that through telehealth or other mechanisms. So I do think this direction has great potential. And I would agree also that it is about both care delivery and financing it's kind of like the whole spectrum. So I think it's really important. I think, and in some ways the way, one way to think about this is that, in that type of collaborative arrangement, you could think about, the utilization management as well as a number of other functions being delegated from the typical health plan function to the providers taking responsibility for that, and then I think that, it sort of changes just where the responsibility lies, and sometimes that can work really, really well. Sometimes it doesn't, but I think it can really, really make a difference. I do think a couple of the comments I think that Jay made me think about the importance of information sharing to support all of this, right? Because he mentioned, knowing when your patients are in the hospital, knowing when your patients are, seeking other care, and so I do think, that information sharing infrastructure and capability really has to be a part of that process to make it work. And that too has been a long journey. We're getting much, much closer in that regard as well. Maybe just one, kind of going back to a second, to the gold carding concept and sort of flipping that a little bit, I just wanted to mention another sort of project that we have underway that's kind of the same idea, but really like focusing the effort on the outlier providers, if you will. So we have a project underway with Dr. Marty Makari out of Johns Hopkins, who has a methodology that he has worked on where he collaborates with specialists to reach agreement on sort of appropriateness parameters for specific procedures. And so, and in doing that in collaboration with specialists, it sort of adds that stature and credibility that comes with that. And then it enables, the use of claims data to kind of profile provider performance, if you will, and only focus kind of collaborative performance improvement opportunity on those outlier providers. So, the gold carding is sort of on the positive side. So for the high performers, we kind of like let them go, if you will, let them keep doing well. This is a sort of another way to say it, but we want to make sure that on behalf of patients that we're encouraging providers to kind of get into the specialist agreed upon parameters. So I think that's another, that could be another part of alternative payment models. But again, a collaborative approach, a data-driven approach that really helps to optimize patient outcomes.
Yeah, that's a great point to note. Yes, gold carding is great because it works really well for really high performing practices, but there are other outliers, if you will, where there's opportunities to focus the work and make improvements there that benefit patients as well. But before we shift into Q&A, and there's one question already teed up that I'll get to in a second. I think from a patient perspective, what I would add is, and when you think about sharing risk and skin in the game, I think patients have always had that, always been sharing the risk, always had skin in the game. Yes, of course, a lot of the payment comes from, if their employer, from the employer side of the plan, contribution. But, patients pay a lot out of pocket outside the benefit design. And of course, literally have their bodies and their lives and their quality of life in the game on the line. So I do think there are opportunities within that sort of concept of alternative payment models and alternative care delivery models to really bring that risk that patients are already bearing into the conversation in a more thoughtful and deliberative way, so that patients can also be part of the evidence-based stewardship, the fiscal stewardship, not exposing themselves to low value care. And I do think there is a care delivery paradigm that really can bring the patient into the process along with their family members and caregivers, along with the clinicians and their expertise, and of course help to achieve the goals that the plans have, which the patients have as well, in terms of quality care, not getting exposed to low value care, overpaying for care, paying for care that's expensive but isn't necessarily going to bring much benefit to the patient. So I think there's a real opportunity here to think about how do you create a delivery model that really, in certain areas, in certain spaces or conditions, and we don't have time to go into that here, but when appropriate, to really bring the patient voice and experience to the table more deliberatively in a systematic process of decision making and reimbursement that does share risk and responsibility to guard against, to really be good stewards of care and quality of life as well. And so I think that's a way of thinking about how to reframe the patient's role, especially. And I think if that's done right and done sort of in, I don't want to say in a goal carding way, but in a way that can be audited and documented, almost like a pathway, that I think plans could have more certainty in approving the outcomes of those decisions if they knew that certain parameters of consideration were built into the decision-making process around evidence-based care, cost concerns, et cetera. Any quick comments on that before we go to the question in the chat? And then, so Kate, Jay, Robin, you want to respond or sort of finish up this part? Robin, I'll go to you, and then Jay, and then Kate, if you have anything.
Sure. I just want to make a general comment, and it just occurred to me in the last several comments that we made that what we want to be certain of is, as we evolve to APMs, is that we don't single out the doctors that are willing to take care of the sickest patients. Some of the concerns that have been presented is that depending on what model you develop, if you're always rewarding high-performing doctors, that's going to leave a patient population that doctors don't want to take care of, because by nature of their disease status and their comorbidities, they will cost more to society. And I'm going to speak as a patient advocate, and what we fight with every day, in my practice, is making sure that those patients are getting the best care. So as we move forward, we want to be very much aware that we don't want to single out a doctor who's willing to take out those risks and start in an awkward way, actually disincentivizing people from taking care of the sickest of the patients.
Yeah, great point, Robin. Jay?
Just real quick, I think that we need to figure out better ways to incent patients to make the right decisions. I think that healthcare is so complex, and people are so overwhelmed at times with everything that goes into it, and they don't want to have to pay a lot. But if we can incent them to make those right decisions, for example, like let's pay them $50 to go get a colonoscopy at a freestanding ASC rather than going to the hospital, and things like that, I think we can help and reach out to the healthcare consumer to help. And the other thing that I was going to say just briefly is, we've talked about a lot of players. The one player we haven't talked about with less skin in the game is pharma. And I think we also need to figure out a way to get them involved and have more skin in the game as well.
Thanks, Jay. Kate, any final word from you on this topic before we go to the Q&A?
No, I think we should go to the Q&A.
Yeah. Well, perfect, because the first one's, and the only one is, so please, if you have, I certainly have some follow-up questions, and we're sort of running short on time anyway, but I'll pose this one to you, Kate, and it comes from Kim. And if anybody wants to put more questions in the chat, please feel free. So the question is, does your work on benefits of electronics, and I assume that means electronic, the prior auth efficiency, does it lend itself to investigating if and how that process may facilitate identification of the best care for patients, in addition to better informing the patient on his or her cost sharing and other administrative issues? So somewhere in that efficiency and the technology that you're developing, Is there a way to identify the best care for patients, and thinking about and really getting them information about their cost sharing and administrative issues related to their care?
Yeah, to be clear, I mean, we're not developing the technology,
Right.
we're facilitating the process, right? Like
Gotcha.
standard.
Fair point.
Thank you, just to clarify. Yeah, I think there's the potential for that. I do think that, you know, just having the information in an electronic format, there certainly is the potential for that. I think initially the focus is on just kind of making, you know, the payer information becoming transparent through an electronic process to the providers. And then providers having that information, it can facilitate the dialogue with the patient around, you know, their options potentially, whether it is medications where they may, you know, have at their fingertips, you know, a drug that may be for that particular patient's benefits, you know, lower out-of-pocket costs for that patient. That's just an example. I think also, you know, it does facilitate the ability on both the payer and the provider side potentially, because the process is electronic, to be able to analyze the information and the performance better. So I think there's the potential for that.
Yeah, and I think part of this speaks to your point, Jay, about incentive. I think maybe part of the starting point there is information. So I think what this question sort of alludes to is that the power of the information, if it's conveyed to patients about what are sort of the evidence-based choices that are before them, and if there is one best choice, you know, that should be obvious. But in a lot of these circumstances, it's more nuanced than that. But how do you get information in the hands of patients about the most appropriate evidence-based choices for their therapeutic options as well? And that also has to have information about the cost associated with those and the other burdens, whether it's quality of life or transportation or caregiver burden. I think that's sort of the information set that I think patients would need or would be helpful to the extent that, you know, that their response to those and their sort of risk tolerance and their preferences would then have some weight in the decision. Not the only weight, obviously, but should have some relevance and weight to what comes out of a decision-making process. Why don't we, there's no more, thank you for Kate for that response. We have just 2 or 3 minutes left. Maybe what I'll do is sort of give you each a last sort of 1 minute comment in this space, and maybe tell us, what do you think is a reasonable timeline? So what is the time horizon we should be thinking, not for the incremental stuff, but really thinking about, is there a way to really, I don't want to say radically, but, you know, somewhat radically infuse payment models and care delivery models in a way that actually could shift the burden of utilization management away from the plan administering that to really a risk-bearing, shared risk decision-making environment with patients and clinicians and family makers, family caregivers sort of helping to drive at what's the best decision for them, and that process would be approved, or the results of that process would result in an approval, kind of a gold carding of the process, if you will, of decision-making and care planning. How optimistic are you, and what's the timeline to think about if that's the goal? So I'm going to pick on, anybody want to start, or I'll just grab somebody. We'll go Jay, and then Robin and Kate will give you the final word.
Okay, we don't have a lot of time, so I'll try to be quick. But off the top, I would say that I'm not optimistic this is going to happen anytime shortly. There needs to be a lot of people who agree, and there's so many factors that come into play, including politically, you know, as it relates to how this is going to happen. And so I think it's going to be difficult. I think the good news is we've made a ton of incremental improvement in a lot of areas around the country. You can cite examples where trend has been lowered and quality has improved. So the cost is getting more affordable, while at the same time, the quality is getting better. So I think we can look to those places as examples. I think we're going to have to see the continued trend overall to happen for a while. And eventually, I think we'll hit a tipping point where we're going to need to make some major decisions to change that. But for the near future, I'd say I'm not optimistic.
Thanks, Jay. Robin.
So from a top-down perspective, I think we're 5 to 10 years away. In other words, a national approach. However, I think from a local level, I think it's ongoing now, and I'm much more optimistic that there'll be solutions at the local level. For example, we're working at CIN with multiple physicians, just not oncology, and employers, and we anticipate and are already seeing change. And so I think that those types of local initiatives and innovations are going to be the next 2 to 5 years.
Thank you. Robin, last word from you, Kate.
I'm going to say I agree with both Jay and Robin. I think that, you know, there are pockets of progress and success, you know, in local communities between plans and providers, but to scale this nationally, you know, I think it's going to be a long journey.
Thank you, Kate. Well, with that, we're at the top of the hour. I'd like to thank Jay Scott, Robin Zahn, Kate Berry for their thoughtfulness in contributing to the conversation and the topic today. I don't want to leave you too. We kind of knew that there is a long path to get to the normative state we'd like to be in, but there is some real opportunities now with incremental improvements. I think we addressed that. I do think, to Robin's point, there are some pockets of innovation and piloting, if you will, of new approaches. Think of places like Yale, Moffitt, other places that are doing some really interesting work around shared decision-making and care planning that really give us hope for a future, but it's going to take a while to really scale that out to a national level. So there's hope, but in the meantime, we do have some real improvements, at least on the incremental level. So thank you again, Jay, Rob, and Kate, and thank you to the Innovation and Access Forum for allowing us to host this topic. Have a wonderful afternoon, everyone.
Thank you.